Hi guys, this is the pharmacology exam review for the first section of 8. So I will be covering this course over the next 8 weeks of recordings. This one is for cardio and blood and lymph section. So we're starting here, and then next week will be endocrine and go from there. I have sent you that outline of the list so you'll know where we are to keep up. Our overview today, 1 of 8, is we're going to cover the cardiovascular, blood and lymph systems, high-yield cardiovascular pharmacology, the blood and lymph pharmacology recognition patterns for pharmacology, and blood and lymph drugs. Most of these notes and this is based on Dr. Christy Fleetwood's Pharm review for the NPLEX, so I wanted to go ahead and give her a reference for that. There is a cross-reference with the current medication list and the areas we need to cover for that. So this is where that material has come up from for me. So we're going to start with first line treatments for cardiovascular disease. We want to make sure we understand what the pharmacology is for hypertension, congestive heart failure, and AFib. And then we're going to go through these high-yield drug classes today, including ACE inhibitors and ARBs, thiazides, loop diuretics, calcium channel blockers, beta blockers, antiarrhythmics, lipid-lowering drugs, anticoagulants, antiplatelets, and blood and lymph agents. So we're going to cover all of these a little bit. We're going to cover the test highlights and then do a couple of rapid recognition exam questions and mini cases before we're done. So our first line therapy means to choose the correct class by comorbidity. So we need to know for sure, what's going on with the patient and what is the first line for that. The mechanisms, we need to know one sentence that defines the class of each of these. So that's those, are they an ACE inhibitor? Are they an ARB? And the drug adverse effects for each one. We need to understand electrolyte shifts, especially with the loop diuretics and thiazide diuretics. And we need to understand vital interactions between the drugs. So when we start talking about warfarin and amiodarone, digoxin and diuretics, there are things that you can't use together. We need to understand what happens when you do use them together. And then we're going to try to match the clinical picture to the patient. Obviously, we want to treat the pathology, not the number on these. I'm trying to get into pharmacology brain fully. These are challenging for me, so to think in these terms, but I'm hoping that it will help at least give you an overview of what we're dealing with the pharmacology world. Okay, pregnancy categories. So the pregnancy categories for the review and prep, they were different. So they used to be pregnancy categories A, B, C, D, and X for drugs, and they have decided to move out of that categorization. Now there are just these 3 sections in the pharmacology FDA classification areas. So pregnancy section 8.1 includes information on risks to the fetus, pregnancy exposure registries, and clinical considerations. And then they summarize the animal and human data, and they may do some pharmacokinetic data and guidance that way. In postpartum, there's also one for lactation, and there's also one for females and males of reproductive potential. So I will probably still be talking a little bit in terms of the previous pregnancy categories, because that was the review I did. So X definitely means never used it in pregnancy. A would be the only one that would be commonly used in pregnancy. And then B is kind of like animal studies don't look good. C is like pretty bad on humans and animals. And D is like don't use it if you don't have to. Biggest thing on the cardiovascular system, pregnancy, your labetalol might come in on the exam. That's brand is Normidine or Trandate. This is an alpha-1 and non-selective beta adrenergic blocking agent. At the same time, So that is the most common. Labetalol is used in pregnancy for hypertension. Also, they gave me nifedipine as the calcium channel blocker that can be used during if there is a preterm labor happening. That's Procardia, or Procardia Drugs is the brand. So the only thing to say with that is that would be a contraindication with grapefruit on this particular drug for the absorption. Um, they do use methyl-dopa. There is a well-established safety record for methyl-dopa for high blood pressure during pregnancy also. That's actually a centrally acting antiadrenergic and sympatholytic. So it basically is calming down the nervous system there. All ACE inhibitors and ARBs are absolutely contraindicated with pregnancy, and statins are contraindicated in pregnancy. So understand these three drugs would be the only ones you'd probably see on the cardio section, would be labetalol, nifedipine, and methyl-dopa. All right, so what are we doing? Hypertension has four main drug classes that we use to treat it. We have the ACE inhibitors, including the lisinopril is the primary one on this test. They used to be first line, but they are no longer first line. Thiazide diuretics are, and this was even first line when I took the review. So thiazide diuretics are the first line now, but ACE inhibitors used to be. Next is first line. They are still used for chronic kidney disease because the thiazide diuretics obviously are going to be complicated there. And for diabetes, ACE inhibitors might be more useful also. ARBs, the losartan is going to be used if they're most of the time when there's an ACE inhibitor intolerance. And then, like I said, the hydrochlorothiazides are the first line for isolated hypertension in older adults. And then we have the DHP calcium channel blockers, which is amlodipine. For Black patients, pregnancy compatible option is amlodipine there. Also, we don't use ACEs or ARBs on pregnant patients. So we're looking for kidney disease, diabetes, heart failure, and pregnancy, and what kind of drug we're using there. So let's start with the ACE inhibitor. So the ACE inhibitor is actually, the mechanism is to decrease the conversion from angiotensin 1 to 2. In the process, it blocks that angiotensin 2 receptor. And so, however, it also blocks the step where we cleave or get rid of bradykinases. And so with ACE inhibitors, there's going to be a potential increase in bradykinin buildup, and that's inflammatory strongly to the lungs and the kidney. So this is indicated with hypertension. It is indicated with chronic kidney disease with proteinuria. So if they're dropping proteins, there is some benefit to congestive heart failure with ACE inhibitors, and it is commonly used post MI myocardial infarction to kind of bring some of the pressure off of the heart. But it does increase bradykinin, so you're looking at dry cough. They estimated about 20% of patients have the dry cough, but if you're noticing the dry cough, that is coming from those bradykinins building up, which can put them at risk for angioedema and hyperkalemia. In particular, increased risk for kidney failure. So if the bradykinin level, most of the time the adverse effects are supposed to happen within the first week, but there has been some cross reactions with IV, with things like IV antibiotics, where people suddenly have been on ACE inhibitors for years and then go into an angioedema kidney failure. So if you see the bradykinin thing happening, for sure with your patients, if you see the dry cough, you want to consider going to an ARB instead of an ACE inhibitor. Not to be used at all in pregnancy. Okay, so the ARBs are the same pathway a little bit, right? But it's upstream, so we're not going to stop that bradykinin step from working, and it's a little bit less effective at lowering blood pressure. The losartans and irbesartans, they have no bradykinin effect. They block the AT1 receptor, but they don't have as good of a impact on lowering overall blood pressure. With the ARBs, you're going to see adverse effects are hyperkalemia and hypotension, obviously, if they go too high. And the biggest thing on the test is if they notice the cough, you're going to move over to the losartan as the second choice. There was one study mentioned here that in losartan intervention for endpoint reduction in hypertension, that 533 African Americans of over 9,000 patients with hypertension and left ventricular hypertrophy randomized to losartan regimen versus the beta blockers, which were atenolol, actually showed a less effective decrease in cardiovascular morbidity. So it did seem to me like these guys didn't work as well with the African American population or Black population. Where you might see this on the test would be the thiazide diuretics are more effective in Black patients in particular. So if you see ARBs or in your own clinical practice, if you're seeing effects, and then their qualifications were basically just like Black skin, so they did not say African American on the general pharmacology, so it doesn't specify if that's darker skin from any country. So if you do have a patient that's not doing well on their ACE inhibitors or on ARBs, then you want to consider thiazides. I think this is why also they've started these as frontline or first line now. So these block sodium chloride in the distal convoluted tubule of the kidney reabsorption. So this is first line. So we're dropping it, we're dropping the blood pressure by taking water out of the pipes here. That is going to increase calcium because we've retained calcium in the thiazide diuretics, which is a little strange. We do lose potassium here. We also lose salt. We can cause hypoglycemia. We can cause uricemia, and we actually do lose CoQ10, magnesium, sodium, potassium, and zinc with the thiazide diuretics. So you guys want to be looking for that replacement in your own patients. Adverse effects here include that acute myopia actually is considered an effect of this, so we can have problems with the eyes, and second angle closure glaucoma can be increased with these. Weakness, dizziness, cramps, and thirst are common because we're dehydrating the patient. This does have high oral availability, and it does have a diminished effect over time, so they will keep having to re-up the dosing. One of the main key pearls she gave on the review was that over 50 milligram dose of the thiazide diuretic does nothing extra on the studies. So not giving them 100 is not going to get them anywhere. So it seems like 50 milligrams is the highest dose that's necessary for therapeutic benefit. So again, on the exam, these increase calcium versus the loop diuretics that decrease calcium. That's good to remember. So your loop diuretics, furosemide. So these block sodium, potassium, and chlorine in the thick ascending loop. These guys can cause, so obviously I'm having a pure loss of water here. Loops lose calcium, so I'm also losing calcium. And in fact, the loop diuretics kind of waste almost all the nutrients more than anything else. So the waste nutrients on loop diuretics are calcium, magnesium, potassium, B1, B6, B12, sodium, zinc, folic acid, CoQ10, vitamin E, and vitamin C all get lost with the loop diuretics. So if your patients are on these, then make sure you're getting some nutrients back in their body. The primary adverse effects include ototoxicity here. So this actually is a major problem. So if your patient is on furosemide and having any sort of ringing in the ears, this needs to be stopped immediately. If it's not stopped, it can actually cause long-term hearing loss or long-term tinnitus. Just the ringing stays there. Oftentimes with the loop diuretics, they will add an additional potassium-sparing agent drug with it to try to keep the potassium in. So spironolactone is used as an aldosterone receptor antagonist. That usually we use for PCOS and hirsutism for PCOS because it actually acts also not just on the mineralocorticoids but on the glucocorticoids and androgens. But sometimes it'll be thrown in here to make sure that people are sparing their potassium. The others, triamterene, spironolactone, and triamterene HCTZ combos are things to look at on your exam list for potassium sparing possibility. Okay, so these do lose all of it, so they're going to want to look at potassium there getting replenished. Calcium channel blockers. So DHP, we have DHP and non-DHP calcium channel blockers. DHP stands for dihydropyridine, chemical structure that makes these drugs preferentially act on vascular smooth muscle. So if it's a DHP, it basically is working on the peripheral vasodilation. If it's a non-DHP, it's working primarily on the heart. So if you remember, DHP is circulation in the periphery, non-DHP is directly on the heart calcium channels. So places where we might see this used, obviously we use it in hypertension, but you might see the DHPs used with hypertension that has Raynaud's or vasospastic angina. So we want the main drug for the DHPs is amlodipine. And it's for using vasodilation in the periphery. Since we're slowing, the blood flow back to the heart, we're taking the pressure off the heart. Amlodipine can cause edema and flushing and headache. So looking for those adverse effects. It's a peripheral nervous system vasodilator. It also does deplete potassium, so you want to look for that as an interesting side effect of amlodipine. One of the DHP is dilate peripheral, might be a way to think about it, versus node depressors is non-DHP, which is the heart nodes. So my non-DHPs here are verapamil and diltiazem. Both of those are going to work directly on the heart to decrease the heart rate, decrease the conduction of the heart. So these guys might cause constipation. Verapamil actually causes constipation, and bradycardia can happen if things get slowed down too much. We want to avoid using non-DHPs when there's any sort of high heart failure that involves increased ejection or reduced ejection fraction. So if the reduced ejection fraction is less than 40%, they're not going to be using things that slow the conduction of the heart directly. If you see ankle swelling with no heart failure, then oftentimes that's amlodipine as the drug. This is pregnancy category, used to be pregnancy category C, so they didn't use it unless they absolutely have to, but it isn't complete contraindication with pregnancy. Let's see, verapamil wastes vitamin E also, but is often used. Verapamil can often be used for AFib, for rate control, some arrhythmias and angina, and for hypertension, but it's mostly used for AFib and arrhythmias, it looks like, to slow the heart down. We definitely want to avoid these guys in sick sinus syndromes, anything going on with the sinuses of the heart, in an AV block, in hypertension, acute MI, or pulmonary congestion. All of these would be contraindicated. So a couple of the just little test questions we might ask would be, which calcium channel blocker would be safest in a patient with hypertension and high frequency heart failure with reduced ejection fraction? So which one would be using if we have HFrEF? And the answer to that's going to be amlodipine, because we want to stay away from contracting the heart itself. Which CCB is used for rate control and AFib with rapid ventricular response? So that then you start thinking, okay, which one are we going to be using to most often for AFib? Actually, AFib is most often treated with diltiazem, which is the non-DHP. So we have verapamil and diltiazem. Diltiazem would be the number one answer most of the time for AFib. If you're seeing which one causes edema, almost always that's going to be amlodipine. And which one should be avoided in systolic heart failure? Both of the non-DHBs, so verapamil and diltiazem, should be avoided with heart failure. Okay, so we've tried our diuretics, we've got our ACE inhibitors, and then we have the beta blockers. So beta blockers are class 2 antiarrhythmics, so their main approach is trying to obviously go after the nervous system effect on the heart. They decrease contractility, respiratory rate, heart rate, and conduction velocity. They also have a smooth muscle relaxation on the peripheral nervous system. So we're really taking them, we're kind of blocking the fight or flight response. The main drugs that we talk about here, we have two categories, either cardioselective, meaning that it's working primarily on the heart, beta 1, or non-selective, meaning it's working more on the peripheral nervous system, blocking. So the cardioselectives are the metoprolol and the metoprolol and atenolol. Both of those are going to be working directly on the heart to slow the cardiac output. They're used commonly with acute MI, so that if someone's had an acute MI, they're going to be given a beta blocker. They're used for angina. They're used to decrease the cardiac output, decrease renin release, decrease angina, decrease oxygen demand on the heart also. So if there's angina, and I just have a patient this week actually that had an event, and they have her definitely on the metoprolol to continue taking the pressure and oxygen demand off her heart while they have her on a variety of other meds to keep the pace and other things going. And then we have the non-selectives, which are propranolol and carvedilol. And these guys are used more on label. They're used for peripheral block, but propranolol often is used for migraine, essential tremor, or pheochromocytoma. Off label, it's used sometimes for anxiety, performance anxiety, and then and for Graves type pictures. So if they're thinking someone has these hyper tendencies, they may be putting them on the non-selectives, propranolol or carvedilol. So you want to look though for fatigue, bradycardia, and bronchospasm, because for specifically the carvedilol can be a problem, or carvedilol is used often with congestive heart failure to kind of take the pressure off. There's an asthma risk with these guys, so you do not, obviously, if we're knocking off sympathetic and swinging that off too much, we want to be careful with avoiding propranolol in asthma cases. The most important thing too for you guys to know with beta blockers is that you do not discontinue a beta blocker abruptly. All beta blockers have to be tapered off. So if you're going to remove these because this patient is over medicated on them, be sure that they're not being used to balance out congestive heart failure and angina. Talk to the cardiologist or work with cardiologists on it. But if you do decide to take them out or reduce, if their blood pressure is managed and their stress is managed, and you want to take them off, you need to make sure you're tapering. You can just discontinue ARBs, ACE inhibitors, and the thiazides without tapering, but that one has to be tapered. Okay, then we also have hydralazine, which is a direct arterial vasodilator. It's to really take the afterload off. It increases nitric oxide availability in the vasculature. And its indications are for pregnancy hypertension, severe hypertension, and then Black patients who have an issue with the nitrates, which is the isosorbide we're going to talk about in a second. So these guys are not used as much, and they're a direct vasodilator, so they're probably going to be ACE inhibitor didn't work, went to a cough, they're going to go losartan, not this guy. Okay, but the main thing to this one can have drug-induced lupus-looking symptoms and reflex tachycardia come up with it. So if any of that shows up on the test, then you want to make sure that you're thinking hydralazine is a little bit more extreme. Let's see. Okay, so antiarrhythmics. So we got through all those major ones. We now are looking at the different antiarrhythmics, and each of these go in a drug class 1, 2, 3, 4, and 5. They really are based on their mechanism as how they do the drug classes. It's not based on how much urgency or what level of care. So your drug class 1 on your antiarrhythmics are your sodium channel blockers. Those are lidocaine and flecainide. You're probably not going to see those in your practice unless you're in the hospital. So these guys, lidocaine shortens the AP wave used for ventricular arrhythmias post-MI. So basically that's being used in the hospital most of the time to, knock the heart rate where it needs to be. Flecainide is a strong sodium blocker. It is contraindicated in any sort of structural heart disease, they say, so then NPLEX seems to love this question. So if you see flecainide, it's contraindicated in heart disease. It can precipitate fatal arrhythmias, so we don't use it unless we have to use it. One of the comments she made on that is it kills as many people as it saves in the hospital. It's kind of a last-ditch effort to kind of get the heart to slow down. Our beta blockers we just talked about, so those are the metoprolol, atenolol, propranolol. They decrease the sinoatrial and AV node conduction, so they are useful in arrhythmias and rate control. So you will see that, but first line rate control for patient is usually that dilpidium is the one for AFib. All right, and then calcium channel blockers and potassium channel blockers. Amiodarone is used for prolonging repolarization. So amiodarone is the most testable on the test. So looking for it. Pulmonary fibrosis. The calcium channel blockers we did just cover. Pulmonary fibrosis is associated with amiodarone, is what I should have said there. So we'll talk about that in a second. Calcium channel blockers we did talk about already, but they're also useful here with slowing that heart down, especially after the MI. And digoxin is the cardiac glycoside we haven't covered much. So NPLEX antiarrhythmic pattern. So just overview here. Pulmonary fibrosis, think amiodarone. Lupus-like syndrome, think procainamide. Contraindicated in structural heart disease, think flecainide. AFib, you're going to always think diltiazem unless there's hypotensive situation with the rapid ventricular rate. So AFib, when they're pushing too fast, is diltiazem. Digoxin toxicity worsens with hypokalemia. So there's a possibility of them putting a question between the cardiac glycosides and potassium sparing, and avoid non-DHP CCBs. If we just talked about that in the calcium channel blockers, we're not going to do the non-DHPs if there's a heart failure with low ejection fraction. Okay, so here's our high yields. The amiodarone is the class 3. This is blocking the potassium channels and multiple other channels. It also blocks sodium, calcium channel blocker, and beta blocker partially. This amiodarone is really used only with recurrent VFib, and it has a reverse dependency, meaning that the more you need it, the less good it works. So the questions they're going to probably put in here, the side effects can be adverse effects are pulmonary fibrosis, thyroid dysfunction, liver toxicity, blue-gray skin, corneal deposits. Amiodarone kind of acts a little bit like it mimics thyroxine, so it actually kind of looks like T4, and so the picture for amiodarone will look a little bit like Graves. So if you're starting to see that with anybody on this medication, they're going to have a very long half-life on it, 40 to 60 days. So you want to make sure that if any of this is going down, they need to get back to their physician. It does increase blood levels of both warfarin and digoxin also. So if you have amiodarone in the game, and that will increase The utilization of warfarin and digoxin, that needs to be adjusted. That seems to be a popular question to not put those together. Obviously would increase breed risk. Okay, AFib. So for stable patients, diltiazem, think AFib, diltiazem as the first choice, first line. If that isn't working for some reason, they do use metoprolol as an alternative, and only use digoxin, the cardiac glycoside, if they're hypertensive or in heart failure. So you're going to primarily see diltiazem with AFib. What she said on it was diltiazem honestly doesn't extend life expectancy on AFib at all. It seems to be mostly to manage symptoms. So if the person is having more side effects from diltiazem than they're having from their symptoms, then you're probably going to want to taper them off of it and not use it. He did say, however, on a lot of the studies that they wouldn't show improvement in the AFib, but when they tapered off, they would notice that they had other effects they weren't noticing had been improved. So sometimes there's a suppression of other effects from the AFib with that med, and people will stay on it just because they aren't so bad on it. So most of the time with AFib, use diltiazem unless there's hypertension, acute heart failure, or COPD and asthma. If this digoxin can cause, if you use it, can cause digitalis toxicity. So look for having to throw potassium at this. Sometimes they'll throw potassium chloride at it if there is a toxicity going on from the digoxin, and that can cause some major gastric irritation. All right, the nitrates. So we've gotten past the arrhythmias, and now we move into the nitrates. Obviously, this is for if there's an event, then we need to do venous dilation and lower the preload, or coronary vasodilation, so that we can relieve angina by reducing the oxygen demand on the heart. The two drugs are here are nitroglycerin and isosorbide mononitrate. They are used in acute angina, or chronic angina prevention. I do have a patient this week that's on, isosorbide now, since she didn't quite have an event, but she was having enough blockage that they worried that she would have one. So they actually put her on this after the stent surgery to make sure the load is down. Common adverse effects. Headache is the most common with nitro. And all of these are going to cause a headache. So they're not used unless you need them, because we're trying to take the heart load down. Hypertension, obviously, since we're vasodilating, reflex tachycardia, trying to get the heart back up to get the blood going, flushing, and tolerance if no nitrate-free interval. So that means, the way they described it is you give the nitroglycerin needs to be given at a dose, and then 5 minutes later, if it doesn't work, you give another dose with the angina. And then 5 minutes later, if it doesn't work, you give another dose. And if 3 don't work, you're in the hospital. So that's kind of the old school version with the nitroglycerin. The isosorbate is used clinically. It said it wasn't on the NPLEX list, but it's good to know. What else here? It's long-acting pulmonary edema. They could be using the nitro for that. Also, more nitroglycerin is short-acting though, so they might be trying to get that a little bit longer. So the biggest thing to look for, again, headaches, flushing, hypertension, reflex tachycardia. This is contraindicated with PDE5 inhibitors, so sildenafil, tadalafil, vardenafil. So any of the PDE5 inhibitors you cannot use with nitro. Those are basically Viagra, right? So if you're looking for a question on the NPLEX, a lot of times it's going to be sildenafil is taken within 24 hours of nitro, or that they're bumping their sildenafil up with trying to take a nitrate to add more vasodilation. The exam question is, took Viagra, don't use it together. Heart failure. Okay, so our core heart failure meds are ACE inhibitors and ARBs, beta blockers, loop diuretics, hydralazine, and nitrates. So Black patients or ACE inhibitor intolerance is happening if with the hydralazine if these other ones aren't working. In heart failure, you want to avoid verapamil, diltiazem, and NSAIDs. So heart failure patterns, you look for improves congestive heart failure mortality. The answer is going to be ACE inhibitors, ARBs, beta blockers, or spironolactone would be the ones you're going to see more often with the heart failure question. I wanted to just throw this in because we're going to talk about cholesterol next. And I did just get this whole study from Weatherby in my email. So just so you guys know, there are conservative cholesterol ranges for the functional ranges. They just are really looking at this differently, both in the female population to male population. And just in general, the LDL and total cholesterol are not always harmful. Mortality is not related to high LDL. It does look like HDL also is not always higher equals better. I'm sure you guys have seen this on the functional panels with your particle numbers. But to really start looking at the triglycerides as the primary metabolic story, understanding if they're absorbing the cholesterol or making it or not, they only make sense and viewed in the context. So cholesterol must be interpreted in context. How much inflammation is going on? How much insulin resistance is going on? What are the triglycerides? And then are they oxidized? So really looking at what is happening with the cholesterol and, not just looking at the numbers. But if we're doing medicine, we're looking at the numbers. So with pharmacology, your main drugs here are going to be statins, which are the HMG-CoA reductase inhibitors. You have atorvastatin and simvastatin on the test. These are going to decrease LDLs pretty good on the numbers on the blood panels. The adverse effects include myopathy and increase in liver damage, so AST, ALT, and there is an interaction with the CYP3A4 pathway, so simvastatin would be an example with that. They're saying if a question mentions a patient on both a statin and a fibrate, so fibrates here are the gemfibrozil, then that actually can cause rhabdomyolysis, right? So if you see a combo test, statins and gemfibrozil or fibrate, then in anything that looks like a myopathy, that's muscle pain, weakness, increased in chronic kidney stuff, then rhabdomyolysis. Then you're looking at that being the contraindication. Also good to know that niacin will increase the myopathy risk if you're taking it with statins. So be careful with the niacin dosing if someone's on a statin. Statins do carry a small risk of muscle toxicity, it says. And fibrates here, so gemfibrozil, lowers triglycerides, but it dramatically increases the statin levels, making the muscle toxicity much higher. So we want not to use those two together. There is also an adverse effect of gallstones with fibrates. Ezetimibe is decreases the cholesterol absorption. So the statins are going to stop us making any cholesterol. Of course, put in your CoQ10 there. The fibrates are going to decrease triglycerides, but increase statin toxicity if the statins are in there. Ezetimibe is going to decrease our absorption by holding out the bile salts, So you're going to actually lose absorption on that. And usually that's an add-on therapy if the other stuff isn't working. So they may add ezetimibe on the statin or onto the gemfibrozil, but you cannot add the statins and fibrates together. That's probably going to be a myopathy issue. One of the clinical pearls she gave here is to actually check the baseline prior to, if you decide for some reason you're starting a patient on a statin, and I know for myself that a lot of patients report feeling less inflamed and better on statins, but it drives me crazy because we're not using our actual medicine and it doesn't increase overall mortality to use it. And especially in menopausal women, having increased cholesterol is actually protective. So please look that up. Not hugely high, but not really low. So we're going to check the baseline. She was saying that if you're taking statins, your numbers are going to look really good within like a week. on the blood panels, within 3 months, they should regulate about where 3 weeks to 3 months is where you'll start to see what the body's actually doing with that drug. And if we're doing actual naturopathic therapies, it's probably better to not check. So if you're using, carnitine, vitamin C, omega-3, balancing the diet, doing all the cholesterol things there, you might want to wait for 4 to 6 months to check the lipids there to see the regulation, because it may look temporarily elevated, and that's not going to make the patient feel good. So wait 6 months out before you start testing it when we're using our protocols. Obviously, red yeast rice is going to kind of fit in the statins category. You would not probably put it on top of gemfibrozil. Okay, so those are our lipid lowering. Now we have anticoagulants. These are high yield only. So this is, you're only going to use these if there's been an event and we need to break down the, the blood coagulation potential. So these DOACs, or DOACs, direct oral anticoagulants, are modern blood thinning pills like Eliquis is apixaban, and Xarelto is rivaroxaban, and Pradaxa is dabigatran, used to prevent clots in conditions like AFib or deep vein thrombosis. So these DOACs are here. We also have just standard warfarin, is probably, I don't know if I've actually seen more people on DOACs than I'm seeing on warfarin, but old school at least was warfarin, which is blocking the vitamin K recycling. It requires you to have an INR between 2 and 3, so they're having to go back in to have their INR checked, and it interacts with a ton of drugs. Absolutely, amiodarone would increase the INR, so be careful in that case. These thrombin inhibition with dabigatran and rivaroxaban is a factor 10A inhibition. So for these guys like the Eliquis and the Xarelto, you're not seeing any INR monitoring. So these can be given longer term. The dabigatran has used to prevent DVT or prevent clots in AFib or in DVTs. And then the rivaroxaban is a little bit more commonly used for longer term management. It looks like direct factor X. Just a second. What am I doing there? Okay. And then the enoxaparin. So these don't need to be monitored and the patient will be on them. I can tell you I've had patients on Eliquis and I didn't love the effects for any of my patients. Obviously, I was happy they weren't having pulmonary embolisms and things, but I saw all of them have weight gain. All of them had depression. So I'm not sure exactly why so much is happening with those, but they did seem like they were pretty hard on the system. Enoxaparin is predictable dosing and used when bridging warfarin. So enoxaparin is used for DVTs, blood clots in the legs during prolonged bed rest, pulmonary embolism, heart conditions. It's preferred in pregnancy. So if you see enoxaparin with a DVT or versus the DOAC, the two of the DOACs, these are the two that are on the NPLEX list, but I don't know why Eliquis isn't on the NPLEX list, it looks like. And then we have heparin. So if we need heparin is mostly used in the hospital. And there's a risk of having this HIT problem, which is, the extreme immune reaction where heparin causes platelets to drop but clotting rise. So it paradoxically requires us to stop the heparin. So we don't want them to have HIT because that can lead to extreme problems if they suddenly stop clotting and start stop the platelets but increase clotting. We get into some damage and potential fatal damage. Go back. Let's see. So all the correct management. So if there's skin necrosis at the heparin injection site is also a possibility, or antibodies against PF4. The answer is on the test is going to be heparin-induced thrombocytopenia is HIT, and the correct management is stop heparin, switch to non-heparin agents, do not switch to warfarin, start warfarin in HIT can cause the gangrene. So that's a big pearl on the NPLEX is to not, You obviously have to stop if there's something with that heparin-induced thrombocytopenia. You're going to stop the heparin, but you're going to be careful with starting warfarin on the test. We have to go to this enoxaparin. Whew. Okay, so antiplatelets. We've got Plavix, which is clopidogrel, and we have, this is going to just knock the platelet factor down. P2Y12 inhibitors. This is indicated for congestive or coronary artery disease, stroke prevention, and post-stent therapy. I do have a patient on clopidogrel along with she's also on the isopro. They have her on the anticoagulant iso. Where is it? Where's my anticoagulants? Oftentimes they'll stack them, I guess is the point I'm trying to make. So they have her on the clopidogrel along with the long-term anti-thrombocytic agent. So the one that's not, that's they have her on the isosorbide mononitrate, which is the fibrate, along with the clopidogrel and a beta blocker, metoprolol, and I think 2 other meds, so statins and another med. And she's having really a lot of problems with fatigue, depression, insomnia. And one of the studies I did look at on female patients, their most common side effects for hypertension and for heart failure. So when they go into an MI, the most common symptoms were insomnia, anxiety, and digestive upset. Okay, so looking at like chest pain, this particular patient did have angina, but a lot of them don't have angina. They're having severe anxiety. Debilitating fatigue, severe anxiety, and then really bad insomnia. And I noticed when they put her on clopidogrel along with the fibrate that she immediately started having severe insomnia and shortness of breath increased, and sending her to the back to the cardiologist to remove some sort of medication from her. They actually increased her clopidogrel and made her worse. So make sure if you've got patients that are post-MI that you understand a little bit about this. They just stack these on each other and really start to create problems. If you see insomnia, anxiety, and shortness of breath and severe fatigue, really consider that being something to refer back to the cardiologist for female patients in particular. Okay, so anyway, the Plavix is for stroke prevention, post-stent therapy. It does have a decreased reaction if you have omeprazole, so you have to be careful with omeprazole and not use it, and use pantoprazole instead. So PPIs and Plavix are no. Probably that's a good question on the test. All right, and lastly here we have the blood and lymph drugs. So this is ridiculous if you work at the Temple Natural Health, because you would use anything we use instead of these, perhaps, unless there's some sort of crazy thing going on with chemotherapy or otherwise. There's an epoetin alpha, so this is our man-made version of erythropoietin. It's used in anemia of chronic kidney disease, and so it's used to help build red blood cells, right? The adverse effects would be hypertension and thrombosis. We obviously, if you have too many red cells, if you build them up too much, you're going to have problems. And then we have pentoxifylline, which is improving RBC flexibility. The brand names there are Trental and Pentoxil. This is used to improve blood flow in patients with circulation disorders, so mostly used for claudication. So if you have someone on the leg pain, claudication on the test, you're thinking pentoxifylline. Interaction with an increased toxicity with fluoroquinolone. So if you have someone that has a kidney treatment or antibiotic treatment with the fluoroquinolones, you need to be very careful using the pentoxifylline. You can have toxic effect. This one is also sometimes used with chemotherapy to try to improve, the claudication caused by the chemo. All right, so rapid recognition patterns include cough. So if you have a person that's on their ACE inhibitor and they have a cough, you're going to switch to ARBs. Angioedema is probably going to be a risk issue with the ACE inhibitor. So you're looking at this person has kidney failure all of a sudden, or angioedema to the kidney is a big deal, ACE inhibitor. General edema is amlodipine. Ototoxicity is furosemide. Pulmonary fibrosis is amiodarone. Heparin-induced thrombocytopenia is heparin. The HIT is heparin. Myopathy is a statin. So especially if they've added gemfibrozil or the fibrate to it. Reflex tachycardia is going to be hydralazines, taking them too low. So hydralazine will be the reflex tachycardia. Warfarin, you want to make sure that there's not a warfarin and amiodarone combo because that will increase their INR. Increased calcium means they're probably on a thiazide, and loss of calcium means they're on the loop diuretic. Okay, quick mini cases here. Number 1, hypertension and chronic kidney disease. Patient 56-year-old with hypertension and microalbuminuria. So if I have this patient, my best choice is lisinopril. So why? Because we have renal protection and we have an increased mortality benefit with chronic kidney disease. AFib with rapid ventricular release or rate. So we have a stable elderly patient with AFib that has RVR. The best first line, and almost always with AFib, is diltiazem. So remember diltiazem for AFib, except for if there's hypotension or acute heart failure. And lastly, chest pain plus Viagra. So patient took sildenafil 4 hours ago, needs angina relief. You do not give them nitro because that will cause profound hypotension. All right, so if you look, your quiz is attached on the email, and you can go in, and the quiz is really covering the ACE versus ARB distinctions, the statin and fibrate myopathies, diuretics and electrolytes, which ones you lose and gain with the different diuretics, rate control and AFib, amiodarone conflicts, warfarin interactions, clopidogrel and PPIs are, you have to sip off of omeprazole. Congestive heart failure medication patterns, and pentoxifilin interactions. Okay, that was a big, thick section. I hope you made it through okay. If you want, you can try taking that test online and see how you do if you're going to be preparing for the exam. And then the next one we're covering is endocrine 1, which is insulin, GLP-1s, SGL2s, thyroid, and adrenal. Will be on endocrine 2 after that. Thank you for coming. I enjoyed doing this, and we'll see you again next week.